first of all like to have a very warm welcome to all our National Board of Examination students. I also welcome our PGDGM students. We have a lot of experts today on our panel. I would like to introduce them one by one. To my immediate right is Dr. A.K. Sood, who is a very familiar face and well known among his National Board of Examination students. He is the Executive Director of National Board of Examinations. I would also introduce Dr. R.S. Mishra, who is sitting to his right. He is the Senior Consultant in Skin and STD in Sri Gangaram Hospital. He was the former ex-HOD and consultant in the Safdarjung Hospital. Then we have Dr. R.C. Sharma, who is the ex-Director, Professor and Head of Lady Hardinge Medical College in the Department of Skin and STD. To his extreme right, we have Dr. Alok Sharma, who is doing his post-graduation Safdarjung Hospital in the same department, and he will be presenting us a case which we can discuss and get a better idea of how to do a dermatological assessment. Basically, we all know that skin is the mirror of all the body functions. Besides, in the general history and systemic examination, the skin is not given its due importance. Hence, it is imperative that we learn how to do a dermatological assessment. This gains all the more importance in elderly since the skin gives a lot of clue to certain diseases which are taking place in the body elsewhere. Now I would request Dr. R.S. Mishra to start the presentation and tell us in details how the history and examination is important as far as dermatology as a system is concerned. I would, sir, request you to start with the history taking.
Thank you, madam. History taking, as is known to the medical students, is the first step when we come across a patient, and this is very important because from the history there are certain clues. As they say, the Sherlock Holmes, he used to say that if you keep on tracking the things in the proper perspective, you will be able to get at the truth. Sequence of events. So first of all, while we are dealing with an elderly person, it is important that we should give sufficient time to the patient to settle down, because he may not be as active and agile as the other younger persons may be. He may take some time to settle. His coherence level may not be all that sharp. So, and then whatsoever the old person says, or the aged person, I will not use the term old, the elderly person says, listen to him intently, so that he should not carry away the impression that perhaps the doctor is not interested in me and he is just giving me a casual, because he has seen the world, so he is very conscious about that fact, that his importance should be no way lessened. After this, when we come across, because he will be talking about so many things which have gone through his life, we must give importance to the fact that the specific thing which we are looking at that particular moment should come to our focus first, because we'll have to sift from the very many other things which he will be talking. So we'll have to talk about the skin ailment which he is coming with, and while we are talking about the skin ailment, we should also try to find out what is the duration. He may not be able to say in one go that how is it, so we'll have to sometime probe him that this thing which you have got, did it appear earlier also, or was it only itching at that particular point and now he is coming across these lesions? And so that becomes important for us to know how the thing has progressed over a period of time, and this period of time may be very variable, from a few days to few months to even years together. He might have had an occurrence say 20 years back, and then he says that he was all right, and now again it is coming up and it is nagging him. So in this context, it is important to think that he has gone through the various phases. He might be taking certain drugs for the various ailments which he may not be able to specify, or he takes it as a routine measure that they are of no consequence. So ask him pertinently what medicine he is taking, and when he is taking that medicine, is there any correlation with that? Another thing of importance besides the skin, is he having any other ailment for which he has come to you to show the skin? The skin is the mirror for all the internal ailments. So he might be having a liver disorder, and he might be having some other cardiac problem, and for those he may be taking medicines. Even if liver disorder is there, he may be suffering from jaundice. And once he has got jaundice, you can just look at his sclera or look at his oral mucosal lesion and you may find that this is different. The fellow may be suffering from anemia, and this anemia will be again manifested. Not that in the general medicine they are of importance, equally important they are in the dermatological context. Then this disease in particular which is coming, ask him very closely about the remissions. Did he have it again, it became alright, and if it has relapsed, what is the precipitating factor for which he is having this relapse? Whether any particular drug was there or any other seasonal thing it is there. Some diseases like, to give an illustration, with regard to the fungal diseases, they may be seen more in the hot and humid climates. So whenever there is a rainy season, this fellow may be having. There may be certain other things like aggravating factors. The person may be suffering from diabetes, and diabetes, whenever it is not under control, he may suffer from the other skin ailments like fungal infections, like monilial infections, and they may be aggravated by the diabetes, because his diabetes is not controlled. So we will have many a time, dermatologist is the first person to diagnose even such simple thing as a diabetes, because the person comes to him just with a simple complaint of itching in the legs, and once you ask him why you are itching, what is the problem, he will say no, I just have it. But if you go in depth, he will say that yes, he had diabetes for which he is taking some treatment, and now we will find that diabetes is not under control. There is the previous treatment if he has taken. If he is suffering from very chronic ailment, what was the previous, and now there is the exacerbation, what was the previous treatment which he was taking, and with what medication it had improved, and what are the factors which are responsible as of now which are precipitating this particular episode. For example, in a disease like pemphigus, which is a vesiculobullous disease, which we may be talking at a later stage, a person is to be maintained on certain immunosuppressive disease like a steroid. And once a person passes through a stressful phase, that level of steroid which he is getting, or which he might not be taking regularly, may prove insufficient, and he may go to. So this stress can be physical stress, it can be a mental stress. All these things, they are of importance. And with regard to the family history, it is important whether he is having this itching or any other member in the family has that. A disease which is very common, like a parasitic infection called scabies, you may find that more than one. The grandfather is there, the child, small grandchild who sleeps with him, he may also be, or the grandchild who has gone to the school and he brings a disease, gives it to the grandfather or the grandmother. So this may be also a situation. So if you low, and the time of the disease when it is, time of the scratching or itching when he is having. A nocturnal itching is very characteristically seen in case of scabies. And environmental factors, they are again of importance. Where does the person live? He may be aware of it, he may not be aware of it. A particular hobbies which he is following, because after retirement he might have gone into certain other things to pass his time. So we may be able to, now we can just have a glimpse at some of these clinical pictures. This is the old man who's complaining of itching and the scabitic lesions, but his wife is also having, the grandson is also having the itching. So this just by the history taking we can come to know that this is a case. This is again, you see the whole face and up to the neck it is involved. So this is the case of photoallergic, the exposed areas of the body which are involved. Another common condition is the airborne dermatosis, and these things with the dust, if it will come, and then the whole of this body surface will be, especially the exposed areas and the inguinal regions and even the armpits, they will be involved. So this is the case of the airborne dermatitis. Next we can see, so this is the one characteristic example is that of the parthenium. Parthenium is just known as the carrot weed or the Congress grass it is known, and it grows wildly. It doesn't need to be cultivated or done anything, and it is very difficult to destroy it. So in the dry weather, when the dust settles, and this dust keeps on flowing from onto the other. Next we come.
I would like to ask you the importance of examination also, like, because history we have taken and details, like you said, in like in any normal individual, in any normal system also, we have to stress on the drug history, the family history, but similarly I think in dermatology we need to stress more on it. And one history more, as you have mentioned, that we need to stress is the environmental history, which we normally do not take in the other systems. So what are the features that we have to consider in the clinical examination also? I would like you to stress the general physical as well as the specifically to the skin.
Very correct, which you have said. The clinical examination is the same as in any other medical clinical examination. But here, considering the person's age, we'll have to, again, as I said, the first point which I mentioned, we'll have to give time to the person. So you give him. And when you are hold the dignity of the patient high, I must say, you must examine him in isolation. Don't try to expose him in front of the other people. And seeing the extremes of the weather, sometimes the hot and cold. In the extreme cold weather, old person will be feeling more cold. So try to expose him part by part. Not that the whole body you expose so that he may start shivering. So that is another important. And then see not only the skin, see also for the other appendages, say his hair, his nails, his mucosal surfaces. They should all be closely examined. And when coming particularly to the examination of the skin can precede the systemic examination or can be followed by the systemic examination. General physical examination and systemic examination are very important part, because skin cannot be viewed in isolation. So in the skin lesions, there can be very closely examined how the earliest lesion appears. That is of importance to us, whether it is a just raised lesion or it is a flat lesion which is a varied color. It can be red in color, it may be little dark complexion in color, it may be a white in color, all those things. So macule can be there, or a papule which is raised, or a nodular lesion can be there. So then sometimes the lesions they will come, or a simple vesicle or a blister may be appearing, is directly it may be coming as a pustule, so which may point to your pyogenic infections. After these lesions, they are by and by, as the time passes, these lesions may change their shapes. So whether it is the healing phase or it is even a spreading phase. So those are known as the secondary lesions of the skin. Whether the lesion has started oozing, it has become erosive, it has become crusted. If it is crusted, what type of crust you are getting? Are you getting the blood tint crust, that is the hemorrhagic crust, or you are getting a just only serum which has exuded on the surface, or it is the pus which has come, so the pyogenic crust you have coming, or the skin surface is trying to shed off quickly. That is the scaling. And this scale can be either adherent scales, they can be there, which you can remove with difficulty, or there can be the loose scales, as in the cases of the disease which we know as psoriasis, where the turnover time of the skin has quickened. Skin which takes weeks to shed off, say 4 to 5 weeks, it is shedding in 4 to 5 days. So the layers of the white silvery crust scales, they will be settling. So all these things we will have to examine.
We also have most of the patients that I think which normally come to a dermatologist have already applied lot of lotions and ointments. So that also maybe it alters the appearance of the lesion.
That's very important. That's very important. You see, a person may not come to you de novo. That is the first time he is coming there, he has not taken any. Many a time they will apply various types of ointment, various types of medications, indigenous medication, or even the allopathic system medication. So the character of the basic lesion might have a change. That is also to be taken into consideration.
Thank you, Dr. Mishra. Dr. Sharma, would you like to add anything on the significance of history and examination?
I would like to emphasize here the history of addiction and habit, which are equally important in the history taking part of the elderly patients. Particularly smoking, as everybody is aware that smoking causing early aging of the skin, and that's very, very important. It depends upon how much cigarettes are being taken per day, how many packs of the cigarettes, and that is having direct effect on the aging of the skin. Second thing, that one should examine the patient with all the things, keeping in mind that patient is elderly, he must have forgotten certain things, he is forgetful, so he should also be accompanied, in such situations should be accompanied by the relations or relatives. That is the importance.
Thank you, Dr. Sharma. Now, I'm sure that in your clinical practice, all the students also must have experienced a lot of cases of dermatological problems, whether they have come to you per se for a dermatological problem or with any other systemic problem and having another dermatological lesion. Now, I would request Dr. Alok has got a patient and he has also already taken the history to save the time and done examination. Of course, he can show you some things of the examination during his presentation. So, I would request that he presents his history and examination, which we can then discuss. Dr. Alok?
Well, I am presenting here a case of 60-year-old female whose occupation is a housewife and is a resident of Delhi. She presented with complaints of multiple reddish raised lesions present over the trunk and extremities, which were associated with itching since last 20 years. The history of present illness: the patient was apparently well about 20 years back when she developed a lentil-sized red-colored lesion over the right leg. Well, this lesion was associated with itching, and within a span of 1 month, similar lesions erupted over both extremities, scalp and trunk. These lesions developed as small red raised lesions with overlying flakes. There is a history of exacerbation of lesions in winter. Patient had consulted for this disease in Deen Dayal Upadhyay Hospital in Delhi, and she was prescribed topical steroids. With no relief, the patient was put on oral methotrexate therapy, 7.5 mg per week, about 2 years back. Her condition remitted, but she left the treatment on her own and her disease precipitated again. There is a history of right knee joint pain present. There is no history of other drug intake. There is no history of urethritis or conjunctivitis present. There is no history of bowel or bladder complaints present. In the past medical history, the patient has a history of trauma when she was hit by a stone about 6 years back. She was treated for right-sided hemiparesis and her condition is fine right now. There is no history of tuberculosis, diabetes mellitus or hypertension. There is no history of atopy, that is, there is no asthma, allergic rhinitis or hay fever. In the family history, there is no significant family history as such, like psoriasis, atopy, melanoma, xanthomas present. In the social history, the patient is a housewife and does all household work. She has 1 son and 1 daughter, both are normal. She is a non-smoker, non-alcoholic and takes vegetarian diet only.
Can you just mention why you specifically asked for conjunctivitis or...
just as a differential diagnosis from other diseases like Rieter's disease is one. So
why did you suspect such a disease?
Because the lesions of the psoriasis or Rieter's disease somehow they resemble. That's why I asked for the history.
Dr. Mishra and Dr. Sharma, would you like to discuss the history first or do we take the case as a whole?
Discuss first the history part.
Yeah, we can discuss the history there.
You have not taken the obstetric history in this patient, and when did she attain the menopause? That you have not mentioned, because that is having hearing. And as you are aware that certain conditions, particularly now there is a bimodal presentation of the psoriasis, you see, the childhood age and the elderly age group. So one has to take this component in this part, particularly in the female patients.
Now the patient is well oriented in time, place and person. As far as the vitals are concerned, the pulse is 80 per minute, regular, and BP is 120 by 170 millimeters, taken about just 30 minutes back. Temperature is afebrile, respiratory rate is 18 per minute, it is ebdothoracic in nature. In the general physical examination, there is no pallor, no icterus, no cyanosis, no lymphadenopathy, no pedal edema, the JVP is not raised. In the systemic examination, first of all, the cardiovascular system, the S1, S2 are normal, there is no murmur or added sounds present. In the respiratory system, bilateral chests are clear. There is no added sounds. In the upper abdominal examination, it is soft. There is no organomegaly and the bowel sounds are normal. Then comes the cutaneous examination. In the cutaneous examination, there are multiple erythematous discrete plaques ranging in size from 0.5 centimeter to 1 centimeter in size are present over the back and extensor aspects of extremities. there is overlying scaling present over the lesions. Now the scales are loose and silvery white in color. The Auspit sign is positive. That is, when we scrap the lesions, a flake comes out and there is a multiple bleeding points which are visible, and the lesions are arranged more in a linear fashion. That is, where the patient itches, the lesion appears, which is known as cobnerization. That is positive here. And few lesions have healed with post-inflammatory hyperpigmentation. Now the hair and nails, the scalp shows a slight erythematous plaque that is exceeding the frontal hairline. The nails show some discoloration and salmon patches are present over the thumbs and the right little finger and the left middle finger. The mucosal involvement, there is no mucosal involvement as such. The oral and the genital mucosa, they are spared.
Have you got any active lesion present?
There is a single lesion present actively, that is on the right thigh.
What is the Auspit sign?
Yeah, when we scrape the lesion with a slide,
can you demonstrate?
well, I will show.
It will not come.
Has she got anything on the upper extremity?
No, on the leg she has a lesion.
Okay, I think then we leave it because it's
Okay.
not. Leave it.
Okay.
Has she got any cobnerization?
Yeah, there are
upper
linear
extremity?
lesions present. Wherever she itches, the lesions
So
appear.
that is wherever she will be scratching along that scratch
Along that
line,
line the lesions
there
appear.
will be the spread of the lesions
Yeah.
are there. And is she all in active lesions are there, or there are certain lesions which have healed and they are?
Many lesions have healed because she is already taking the
So
drug.
what are the types of secondary lesions? Which is she? I think she has got hyperpigmentation somewhere.
Yeah, she has
Can you show it on the upper arm?
Yeah, there is one such lesion here.
You see.
That is a
All the
post.
lesions I think which they have healed, they are now showing only this
Yeah,
pigmentation.
that is a post-inflammatory hyperpigmentation that is present.
Hyperpigmentation.
Yeah.
And mucosa is not involved.
Mucosa is not involved. Oral and genital mucosa, they were both normal.
Now, have you seen the nail changes?
Yeah,
here?
nail changes are
Can you
there.
demonstrate the nail changes
Yeah,
here?
there
The
are
nail-
salmon-colored patches present.
That-
Now, this is a salmon-colored patch that is present here on the left
And the
middle
ridging.
finger.
And the ridging in there and
Ridging is
subungual.
there, yeah.
Subungual keratosis.
Subungual hyperkeratosis is also
Just under
present.
the nail plate.
Yeah.
In the distal end, you
Yeah.
will get.
You can just raise her hand a little bit so that it can be seen. Yeah.
Yes, yes. Pitting also. Did you see the pitting?
Yeah,
Pits.
Is there pitting present on the
there
nails?
are pits present.
So can we go on to the diagnosis, provisional diagnosis maybe?
Yeah, the diagnosis was generalized plaque type psoriasis.
You based your diagnosis on the particular features,
Yeah.
the clinical features, that is the skin loose scales,
Yes, sir.
which were present,
Yeah.
and there were on the scalp you got the patchy erythematous,
Patchy erythematous,
scaly
yeah.
lesions,
Yeah.
plus the nail changes.
Moreover, the lesions were well localized
Mhm.
and they're erythematous with overlying scaling. So that gives more to the favor of psoriasis.
What are the differential diagnoses you will consider?
Differential diagnosis will be lichen simplex chronicus, we can say, seeing the age of the patient. Then we can also think of mycosis fungoides, that is more common in old age.
Why will you say it is not seborrheic?
Seborrheic dermatitis will be
especially
more
with regard
present
to
on
her
the
scalp
seborrheic
lesions.
distribution. It will have more
In the
common
scalp
of the
lesion.
seborrheic like scalp, upper
How
chest.
these psoriasis lesions will differ from the scalp will differ from the seborrheic lesions of the scalp?
Seborrheic dermatitis will be more diffuse in nature,
Yes.
and psoriasis will be well localized in nature.
And the scales?
And the scales will be loosely adherent in case of psoriasis. And
In the case of the seborrhea, it will be yellowish greasy
yellowish
scales.
and greasy also in nature.
While in this case, there will be dry scales.
Dry scales.
From the learner point of view, I would like to know that in this differential diagnosis, because the way that our students are, they are all doing general medicine, or they are basically physicians as family physicians. So when they will be seeing such a kind of a case, then they will probably not be able to make a pinpoint diagnosis, but maybe have 2-3 provisional or differential diagnosis in mind. So is the management in these 2-3 differential diagnoses different or same? And I would request Dr. Mishra and Dr. Sharma to comment that when we see such a case, like our students, when they see such a case, then what they should do, whether they should be able to manage such a case, or whether they need to take an expert comment from a dermatologist. to be able to manage such a case? I mean, if normally the management is the same for the similar types of differential diagnosis, then it's okay, there's no problem in trying the treatment. But if the differential diagnosis have got absolutely tangential management schemes, then naturally it is better probably to take an expert opinion. So I would request that you can comment on that.
Certainly, it needs specialist attention for the management of such cases. One should know whether it is stable or unstable, because the management of the psoriasis depends upon the stability of the psoriasis. If stable, then the treatment is comfortable for the psoriatic patient. And for the differential diagnosis patient like seborrheic dermatitis, lichen planus or mycosis fungoides, as he has mentioned, and other conditions, because all other conditions needs different treatment, so it needs the specialist opinion. And recognition of the lesions like psoriasis, one can recognize by having lesions like this in the patient, and one can refer easily to the specialist, particularly dermatologist. Professor Mishra.
The point of importance which Dr. Sharma raised is that since skin psoriasis is a chronic disorder, so, and especially when you talked about the referring the patient. Yeah. So at least for the first time, if the diagnosis is confirmed by a consultant or a specialist, then the disease will be recurring again and again. If a general practitioner knows the principles of management, then on subsequent occasions, if there is no other changes, because certain changes they can occur in a case of psoriasis, which is called the psoriasis vulgaris. If it is going into the exfoliative dermatitis, if it is having other changes, pustular psoriasis or others, then only a specialist consultation is the, but others, ordinary type of psoriasis, that is psoriasis vulgaris, if the clinician is competent enough, he feels confident, then he can certainly handle after the confirmation of the disease at the first time at least.
I think maybe this will be true for most of the ailments, that once there is a skin disease which is presented by a patient to a general physician or to a family physician, then once he is able to probably diagnose that there is some dermatological problem, it is probably always better, would you say, to first take a specialist opinion and then maybe to manage the relapses, and or are there some lesions which they can recognize? For example, scabies is probably one thing which they will be able to pick up. So are there certain other diseases which they will be able to pick up on their own and manage it?
The most common skin ailments still in this country are the infective disorders. Say pyogenic infections, bacterial infections. So they can be managed at the level of the general practitioner. Then fungal infections, the dermatophytes, that is superficial fungal infections. They can be managed to a great extent by the general practitioners, but for the others,
I would request Dr. Alok to just show the learners the various equipments or that a dermatologist should keep handy while examining any patient, because that I think is very important. You were showing a hand lens, so is there any other equipment that you have and you feel it's important?
Yeah, this is a glass slide. Now this can be used for like I just did here, the auspit sign for scraping the lesion. Then there is a cotton here which can be used for the sensation checking. Then of course a torch to test the mucosa. Then this is a needle to check whether the lesion is a vesicle or bullous, or and also to check the sensation as well. Of course the stethoscope part for the systemic examination.
And I think these days, if you are thinking that is an infective disorder, it is more important to wear the gloves, protect arms. That is the general.
Yeah, the gloves, of course.
So, not that all cases are infective. By and large, most of the cases of the skin disease, they are not infective. So, people should not go away with the impression that anytime you see a skin patient, you have to wear gloves. But certain infective disorders, yes. And especially in these days, when you suspect, you see every person, whether he is HIV or the AIDS, so then all the more precautions. Clinicians should also take the necessary precautions.
That is true for not only dermatology, universal precaution for all the physicians in any practice. Yes. One should take universal precaution.
Thank you, Dr. Alok, for a very nice presentation. I would now request Dr. Sharma to tell us what is aging of the skin and what are its basically features, the features of aging of the skin.
Now you have seen this photograph of the elderly person, and aging has been defined that true aging and photo aging. True aging is just like the during the passage of the time, which is inevitable and which is genetically predetermined. So that is called true aging or intrinsic aging. The second is photoaging. Photoaging, that changes due to sun exposure on the skin imposed on the already aging skin. That is called photoaging. So this is the definition of the aging of the skin. And what are the normal features one can see in the elderly person? The feature of the aging of the skin in the elderly person, particularly true aging or intrinsic aging, and there are morphological features. One will see the wrinkling, sagging of the skin. Now one can see on the face particularly that there is a sagging of the skin taking place on the lower side of the cheek, and particularly on the hand also showing the wrinkling as well as sagging of the skin. Then there is fragility and dryness of the skin and uneven pigmentation. So dryness is the component of the aging skin because it's due to changes taking place in the epidermis, and epidermis getting abnormal and impaired functions. That's why the dryness is there. Uneven pigmentation one can see on the skin, particularly third slide, where one can find the hyperpigmentation, hypopigmentation, or presence of the lentigens. Hypopigmentation usually seen in the elderly persons in the form of the idiopathic guttate hypomelanosis. And other component of the aging of the skin, one will find altered skin surface pattern. One can see normal skin pattern which is having crisscross lines, very fine crisscross lines over the skin. In elderly person, there is alteration and disturbed skin surface pattern, and that is the result of underlying pathological process taking place in the skin, and that is due to epidermal changes as well as dermal changes. There is thinning and graying of the hair, which is universal in the elderly person. So these are the morphological changes taking place in the elderly patient.
Dr. Sharma, there are some functional changes also probably which take place due to old age, because of which probably these morphological changes occur. So what are those functional changes which occur?
There are certain functional changes which are declining according to the age. There the decline in the following skin functions. That first is barrier function, where it is getting impaired or decline in the barrier function of the skin. Second is the immune responsiveness is also disturbed in the elderly person. And wound healing is also delayed. And there is the cell replacement which is also getting delayed. And there is a delayed chemical clearance. And there is a delayed sensory perception in the elderly person. And there is delayed or impaired thermoregulation. Patient should not be exposed to the vagaries of the weather, extreme cold or extreme hot. So one should take care of that thing also because there is impairment in the thermoregulation. Then there is a sweat production also reduced in the elderly person, as well as sebum production also getting reduced, and there is vitamin D synthesis getting delayed or disturbed in the elderly person. And DNA repair also delayed, and hair and nail growth also impaired, and there is the decline in the function of the melanocyte. That's why you will find uneven pigmentation in elderly person. Due to this thing, there will be a hyperpigmentation or lentigens or different type of melanocytic nevi, or there is guttate hypomelanosis. So these are the functional changes one can see in the elderly person.
Thank you, Dr. Sharma. Dr. Mishra, would you like to add anything to these changes, morphological or functional changes?
Most important change which is occurring and which is showed in the first few slides is the thinning of the skin. And on that depends so many other changes with the functional changes which occur. That is, the epidermis is also thin. That is just become, instead of the ratty patterns which are there, they are almost straight. And even the dermis is very, so that is the old age skin looks thinned out, and the wrinkling and other things they occur due to that. And that is why it is important to take, even for an old person, whenever we are advising, we should advise that he should take good care of his skin. And the dryness of skin also follows from the same. So especially in the extreme winters of the North India, he should always apply a emollient. When the evaporation is too much, the drying is too much, the simple thing is just to apply a little emollient after the bath, so that to trap that the moisture or the water content which is there on the droplets of water which are there, It is the most important. Simple things like this they follow.
Thank you. I would request Dr. Sood if he would like to mention something, especially to his National Board students. Yes,
thank you, Dr. Ruchika. In fact, for the benefit of DNB candidates who are watching this program, I will this is some information I will like to give them. First information is that please refer to our website netboard.nic.in. There you will find some sample questions also for theory examination, because we were receiving lot of requests from many students that they should get previous year papers. So we have put for each major subject sample questions, the same pattern may be followed for their examination also. So just to give them what type of question can be asked in the theory examination. Second important thing in the website we have put is, and in some subject already it is there on the website, especially for case presentation, for the benefit of students. We have asked the experts, they have given us a write-up, 3-4 page write-up on what are the salient points in history, what are the salient points in clinical examination, what are the important investigation and management aspects of all important, you can say, common cases in various subjects. Already for 6-7 subjects we have put this on the website, and maybe dermatology we are going to put on the website very soon. Third piece of information is that we have already, I think, that in the process of launching a journal, a National Board of Examination Postgraduate Journal of Medical Education, Training and Research. So I take this opportunity to request all the students and our consultant in various hospitals to contribute to our journal, to contribute to our quarterly newsletter. You can write about your hospital, you can write about your institution, you can also write about experiences regarding DNB training programs, as well as if you have completed your thesis, you can send us article for that. Basically this journal is for you so that you can share your experiences, and basically to provide you a forum whereby we can have a sort of for all DNB candidates a forum where they can.
Thank you, Dr. Sood.